So we are on episode 5. This is the 5th of our series, and today's topic will focus on ACLS in COVID-19 and the implications for anesthesia. We have two of our nurse anesthetists presenting for us. The first one is Steve Thuo from Kijabe Hospital. So Steve, can you wave to the people so that they can know who you are? Yes, so that's Steve. He has his hands up. So Steve is from Kijabe Hospital. He's a nurse anesthetist who has been working there for more than 5 years now. I hope I'm right. And he's also one of the trainers for the KRNA program that is being conducted there. So Kijabe is actually is the first KRNA nurse anesthetist training program in the country. So welcome very much. Our second speaker today is William Litu. William is the guy with the many flags behind him. So and including the Kenyan one. So thank you for representing our country. So William is from Vihiga County, which is on the shores of Lake Victoria in Western Kenya. So he's also he was trained at Kijabe Hospital, and it's good to see teacher and students joining us on the same panel and sharing with us a good thing. So I see we have participants from Ghana, Uganda, Busia, which is just in the border of Uganda. So I'm happy to see that we have people from very many parts of this country. Also on the panel is Macton Okoth. He was one of our presenters last week, so he'll be helping me in case I need to step out a bit, so and just helping us guide this discussion. So I'll hand it over to William to take it from here. So Phil, welcome. If you have any questions, please use the Q&A section to ask the questions, and we'll answer them at the tail end of this meeting. So karibuni sana, and we are happy to have you all. So William.
Thank you, Gatwiri. Hello, can you hear me? Okay, welcome guys to our 5th episode of Let's Talk COVID-19 webinar. Like Gatwiri had said, my name is William Litu. I work at Vihiga County Referral Hospital. And let's just go straight to the introduction. So we are dealing with the cardiac arrest in OR. And cardiac arrests in OR can actually, it happens. Usually it is witnessed or often anticipated. Why are we saying this? Because this is a patient who would have, we assume that this is a patient you have already done pre-op, so that you know what you are going to deal with in theater. You have some anticipated steps that you will take during OR. So in case of a cardiac arrest, actually it will be witnessed. This is not like the same with the one that you can find in the wards, where you are called that the patient has coded. And response may be more timely and focused, because in OR we always advocate for vigilance, whereby you monitor the patient from the time you put the patient to sleep, during intra-op, and post-op. So vigilance is actually our key thing that we need to do. So we are saying response may be more timely because you have vigilance. And then it is very different from other in-hospital and in-hospital or out-of-hospital arrest. Just like I had said, this is a patient that you are with and you are doing monitoring, and you know this is a patient you have done pre-op, you know what you're dealing with. So it is not like the one that will be called the patient has coded. This will be a witnessed arrest. So there are different pathophysiologies that could cause this. One that is top of the list would be hypovolemia, which is more common than MI. Then prolonged hypoxemia and hypercarbia from management of unpredictable airway. And why are we saying unpredictable airway? This could be because of if you have a patient and the person who is doing the intubation is not an experienced person, you might have challenges during intubation, and this could cause prolonged hypoxemia. Yes. Next. Let's go to the next slide, Steve. So let's look at the causes of cardiac arrest in OR. So we have divided these causes into two. Those are, that is loss of airway, the respiratory causes, and actually three causes. That is respiratory causes, cardiovascular, and anesthesia causes. So if we start with the respiratory causes, we first of all have loss of airway, and this can happen because, say, the patient is under general anesthesia, and we have a term we use to note this. We use a term called DOP. DOP, the D stands for displacement of the tube. This can happen, and you need to be vigilant, like we had said earlier. There could be obstruction of the ETT because maybe there's a mucus plug or there's a kink, and maybe there's a pneumothorax that you've not identified, or equipment failure. So loss of airway is top of the list where this can cause a cardiac arrest. We also have failure to control airway, just like the acronym DOP says. We have hypoxemia, and we also have autopy. Autopy can occur where the airflow does not return to zero at the end of exhalation, mostly in patients with the COPD. So like we had said earlier, you actually need to have pre-opt these patients before surgery. Then we have acute bronchospasms. Next. On cardiovascular causes, we could have a vasovagal reflex, hypovolemic or hemorrhagic shock. This is common. If a patient is bleeding too much, you will have hypovolemic shock. Surgical maneuvers associated with the reduced organ blood flow. Yeah, this can happen. We have gas embolus. This basically means there's a blockage in the veins or arteries that the blood is not able to reach the vital organs, which is the heart now. And then acute electrolyte imbalance. So you need actually to know what is the electrolyte profile of this patient so that you anticipate for such cases. And then increased intra-abdominal pressure. You know, this one can happen when you press on the IVC and there's no return blood flow to the heart. Thereby you can have a cardiac arrest. And then transfusion reaction. This one is not common if you have done all the required steps when you are transfusing the patient. So you do GXM to find out everything about the blood. But we can't say it cannot happen. It is not common, but it can happen. Yes. Next. So continuation of cardiac causes, anaphylactic reaction, maybe from the drugs that you've given, attention pneumothorax, acute coronary syndrome. Yeah. These are conditions, these are syndrome. You see, it's called a syndrome because it has several conditions that are associated with sudden or reduced blood flow to the heart. Yeah. Then maybe pulmonary embolus, basically a blockage from maybe gas or blood or a blood clot, severe pulmonary hypertension, prolonged QT syndrome. QT syndrome basically means that your ventricles are not pumping enough blood out. So that could cause an arrest. Ocular cardiac reflex. This is whereby there's a lot of pressure on the globe of the eye. So this decreased heart rate by about 10% following pressure on the globe or fraction of the ocular muscles. This could cause ocular cardiac reflex. And then ECT therapy, that is electroconvulsive therapy. Then if the patient has a pacemaker and the pacemaker fails. Yeah. Next. So some of the anesthetic causes. We have the first two ones are overdoses. That is, if you're using IV anesthetic doses, anesthetic drugs, and you overdose the patient, yeah. And this can happen if you have not pre-op the patient, you don't know the weight of the patient, you don't know the profile of the patient. This can happen. And then inhalation anesthetic overdose. Maybe you put a lot of gas and you forgot. This can happen. That's why we are talking of vigilance during intra-op. Neuraxial block with high level sympathectomy, where the block goes higher than the you basically overdose the patient. Then malignant hyperthermia and drug errors. So important clinical perils you have to note. We talking of preoperative evaluation will actually help identify anesthetic concerns early. During pre-op, review recently prescribed or given drugs. This will give you an indication if the patient had a reaction from the drug or not, so that you know how to manage the patient. And we are saying if the surgery is not an emergency, you can hold the surgery you can hold the surgery, yeah? You also need to do room preparation. That is, assess oxygen source and circuit integrity, ensure everything is in good condition, so that you don't have mishaps. And then vigilance. We've talked about this so much that you need to actually be vigilant. Early recognition of true crisis. Do not rationalize too much in the face of a crisis, whereby maybe you are seeing a monitor is giving you certain values and you're saying, oh, maybe it could be the, don't rationalize too much. Just deal with the crisis, yeah? Then call for help early. It is not a sign of weakness if you call for help. This is actually a sign of strength. And when you're calling for help, it is prudent that you mention COVID-19. Why are you mentioning COVID-19? Because we will look at it at a much later stage, that COVID-19, you have to protect yourself first. So all those who are coming to help you in this case, they need actually to stop and protect themselves. So you actually need to warn them that it's a COVID-19 patient. Then utilize the current BLS and ACLS algorithms. I think Steve will take us through those at a later stage. And always confirm airway positioning and function. When you're dealing with asthma or COPD patients, check the ventilation settings to prevent possible auto-PEEP, and then treat the H's and T's as we will look at them at a much later stage. And these are major reversible causes of cardiac arrest. Yeah. Thank you.
Yeah. So now let's look at resuscitation in the era of COVID-19. We'll talk about some updates, and then I'm going also to continue from, and in addition to what William was talking about, we'll also add some more clinical peril, just some tips to help you as you take care of patients. Now, I know we are talking about cardiac arrest in the operating room, but I think, as you know, cardiac arrest can occur anywhere in the hospital or out of hospital. But when we talk of cardiac arrest in the operating room and ways to prevent that, one of the points that we would share with you, and we got this from WFSA website, is you need to think about the people, the personnel, protection, supplies, intubation, and extubation. So slowing down is safer for you. If you have an unstable patient who you think that the surgery is big and you know that they may be very unstable, always optimize the patients before they come for surgery. And that can be done through preoperative assessment, team briefing, and having a plan, and also optimizing the patient before that. In this era of COVID-19, minimize exposure for yourself, the patient, and people around you by all the things that we've been learning in the past series. And we'll also talk about that as we continue. And also anticipate the patient needs and have all the equipment that you need before you start the case. And also think about how you can minimize aerosol generation during intubation, extubation, and I can add during resuscitation, and we'll talk about that. So this slide here is trying to show us what things do we need to do before a patient arrives in the operating room and when they are inside the operating room. We need to plan before they come into the room, and that's prepare and plan, and also what we need to do during intubation and extubation. So we are going to share some of these notes with you. Gatwiri will follow up on this, so I don't need to go into details about this, but the past presenters have also talked about things that we need to do before a patient comes into the operating room, the care we need to like donning for ourselves, the care we need to take care like for the machine and so on. So I'll go straight into the things that are important for resuscitation. Now, it is always very, very important that if you are recognizing you might have a problem, call for help early. We don't need to always call for help when the patient is unstable. Or when they're in cardiac arrest, if you recognize that a patient is very, very sick, you can always call for help ahead of time. So let me give an example. If you have a very unstable patient, or they are stable, but then they start desaturating, their SpO2 is going less than 88%, and you are giving them 100% oxygen for more than 15 minutes, despite you taking care of all the measures that William talked about, I think it's good to call for help. Like he said, it's not a sign of weakness. If you're in a facility where you are able to do ABGs, and you can look at the numbers and you recognize that they are very low. For example, pH is 7.25, more than 2 readings and so on. The PaO2 is less than 40. That's a very, very sick patient. If you can be able to do the ratio for SpO2 via FiO2 and it's less than 150 for 2 hours, that's, I think, a severe situation of ARDS. I know ARDS diagnosis is from 300, ratio of 300, but for COVID is probably 150. So you would want to call for help early, because if we don't address the hypoxia and acidosis, then we have to know that we'll end up resuscitating the patient. And also, if you have high priority alarms that are in red, they can't resolve, manually ventilate the patient as more help arrives, and try to rule out other problems that may be occurring. So, what things do we need to know about ACLS? One, always protect yourself. And we've talked about this a lot. Complete hand hygiene, PPEs before the patient enters the room. Make sure you gather all the equipment that you need for taking care of the patient, and also reduce aerosol generation if possible. Call for help early. Do not delay calling for help or intubation if a patient is not improving with less invasive procedures. Another point is reduce the risk. So are you able to use low flow oxygen, for example, use of nasal cannula or non-rebreather mask? Can a patient wear a mask, and then you can put the oxygen mask over it? do you have a filter in place to make sure you're protecting the patient and also making sure that your machine is not going to be infected and so on? And also ventilation goals are very, very important. Ensure that tidal volumes are low to protect the lungs. We know that the normal tidal volumes are 6 to 8 mils per kilogram. So I saw that the low tidal volume recommended is about 6 mils per kilo. And then for CPR is because we are now advised to intubate patients early. During CPR, you could pause chest compressions to intubate the patient very fast to minimize aerosolization when we are doing bag mask ventilation. And it's important that we communicate very clearly, closed loop communication during resuscitation, so that we can alert the team leader who are doing chest compressions, maybe other things that are going on, so that we ensure their safety also. One of the things that I may add concerning this point, number one, protect yourself. We know that in the OR we are required to be donning PPEs. And one of the days I tried in our SIM center to don for a CPR, it was a safe environment. We were not with a real patient, but I realized I took about 2 minutes to don, and it could be easier for you if you're in the OR, if you're already donned. I think as more people come in, there might be delays, and we would want to make sure that we communicate clearly so that we don't delay doing CPR. So this is just a diagram to help us sum up what we've been talking about. Depending on where you are, it would be good to think about the number of personnel coming into the resuscitation room. I think in many of our operating rooms where we live, that we have few people. So I don't know what it means to you to limit the number of people in the resuscitation room because we are always few. But if you're in an environment where too much help is a problem, you could think about minimizing the personnel inside the operating room. So what has been added from the guidelines in ACLS? So for purposes of this presentation, we are using the American Heart Guidelines. So what has been added is before you start resuscitation, make sure that you don full PPE. If, of course, you have many people with you, reduce the personnel. Running an ideal code for resuscitation would probably be about 6 people. If we we have a team leader and everyone has a role. I think most of our theaters, we don't have such huge numbers of people at any one time. Maybe during the day is possible. At night is really, really hard, but it's good to think about it. If you also work in an environment where you have students, we need also to think about limiting the number of personnel. And then consider resuscitation appropriateness. For example, start CPR early. The more we wait, donning, the less likely we will have a successful resuscitation. And also, as we give oxygen, we need to limit aerosolization. And what that means is we need to make sure that the mask seal is tight as we prepare to intubate the patient, especially in a situation where they are desaturating really fast. And also, then run the code. Then after we have intubated the patient, we resume CPR. If you had started CPR before intubation, you can pause chest compressions so that you intubate. Remember, during intubation, we want to spend as minimal time as possible. And depending on the patient you have, you need to prepare for intubation. Whether it's a normal intubation would be much easier. If it's a difficult airway, then that's something you need to think about. If you are delaying intubating the patient, you are taking more than 30 seconds to do intubation. Ideally, we should take about 15 seconds, I think. But But if we are delaying too long and the patient is desaturating, it would be better to use a supraglottic airway or bag mask the patient with a filter and we have a tight seal. Then after that, we could continue bagging the patient, or you could connect them to the ventilator where possible. The depth of CPR does not change. For adults, is the same, 5 centimeters or 2 inches deep. Remember, chest compressions are hard and fast. We want to achieve at least 100 to 120. Avoid excessive ventilation. We want to give a breath if a patient is intubated, we are giving a breath every 6 to 8 seconds to make sure we have about 10 to 12 breaths a minute. And every cycle after 2 minutes, we want to make sure that we switch on the person who is the compressor and with another person, because chest compressions can be very, very tiring. The defibrillation has not changed. If you're using a monophasic defibrillator or a biphasic, the standards are the same. Even the use of epinephrine, that does not change. The rhythms when we shock the patients, that does not change. But remember, as we do chest compressions, when we talk of the reversible causes, that's H's and T's. The H's are 5 of them. We have hypovolemia, hypoxia, hydrogen ions, hyper or hypokalemia, hypothermia, I think I saw in one of the slides we have hypoglycemia. Hyperglycemia is not there, hypotension is not there, it's just part of hypovolemia. And then T's, we have tension pneumo, cardiac tamponade toxins. Toxins could be sepsis or drug overdose. So we would want to treat that. For example, if a patient had magnesium sulfate overdose, we know we will need calcium gluconate. And also we have thrombosis, that is pulmonary or coronary thrombosis, and we treat that. In pediatric patients, remember, we will still don PPEs, and we also limit the personnel. Do not delay to start CPR. Ventilate the patient with oxygen using a bag mask device with a filter and a tight seal to avoid too much polluting the environment too much. And also consider intubating early. So prioritize intubation. You could pause chest compressions to intubate really quickly, then resume CPR. But if you are going to delay intubation, it is better to use an LMA or continue bagging the patient, provided you have a filter and a tight seal. The chest compressions have not changed. If you are doing chest compressions for a child, it's different. The defibrillation is also different. So we wouldn't, those are the only things that have changed actually. So we donning PPEs and when to intubate, and if you don't intubate, what should happen? Okay. If you don't have an advanced airway in a pediatric patient, you would do compressions at 15 chest compressions to 2 rescue breaths. And also, if you are 2 compressors, if you are 2 rescuers, you would also want to make sure that you are switching the compressor to ensure that we continue giving quality chest compressions. In summary, we would say the following. 1, during CPR, ensure high quality chest compressions. Minimize interruptions like we don't want breaks during chest compressions. The only time that you would post chest compressions, we know there are 2. 1, when we are reassessing the patient, or we are analyzing the rhythm then, or we want to intubate the patient. We will give oxygen, but we want to give low flows. Or if we have to give high flow oxygen, we make sure that we have a tight seal and we are not polluting the environment. And then as we are doing chest compressions and rescue breaths, we want to ensure that we address H's and T's. Yeah, and also donning is important. And also remember, when you complete the procedure, when you are doffing off, it's good that someone observes you doff or removal of your gown, gloves, and mask and face shield, so that to ensure your safety, so you don't contaminate yourself. This part on the right here is talking about doing extracorporeal CPR. We don't have that advantage where we live, so that this is from the British guidelines. So it doesn't apply in many of our settings. An important point that we would want to address during this lecture is ethical considerations during resuscitation. There is a big discussion going on. Do we resuscitate COVID patients or do we not resuscitate them? So first of all, the British guidelines and the American Heart have come up with the BLS ACLS algorithm for COVID-19 patients. So it is okay to resuscitate a COVID patient. So your decision to not resuscitate a patient has to be ethically justified. Is it, do you want not to resuscitate because they have coexisting disease that their survival is very, very limited? I mean, ethics have to justify your decision, your tragic decision, because we've put this word tragic decision here because a patient will end up dying if we don't do resuscitation. So, you know, we all know about ethics, and we are all responsible for upholding the highest level of ethical standards professionally according to our country's laws and also according to WHO guidelines. So if you need to resuscitate patients, go ahead and do that and ensure everyone is safe. Are you working in a resource limited environment where you don't have an ICU, you have only one anesthetic machine and you have to do many cases that day? It is very, very important that such critical and serious issues be discussed as a team in a manner of transparency, inclusiveness, consistency, and accountability, so that when we make a decision to resuscitate a patient or not to, we are all working as a team. And also, it is also very, very important to communicate to patients, their families, and with all healthcare team members, because we want to ensure that we are all at the same page. So, what do we conclude about resuscitation? Yeah, patient-centered care is at the core of our care in focus, and we are aware of the challenges that we've all gone through taking care of critically ill patients. As a team, especially this corona season, it's good to make sure that we all communicate, like I said, in a transparency manner, in a way that we will all understand other team members in the healthcare, patients and their families, so that we reduce the psychological trauma that comes with very critical illness. And also, planning early is very important. It's better to prevent a cardiac arrest situation if possible. And also being vigilant for any complications that may occur wherever you are. And also when such complications occur, you know how to address them. Now, this diagram I've put here, you can see that this is a mannequin in a simulation center, and someone is trying to intubate them when the mannequin is covered with a polythene. So I have seen that in simulation centers now are trying to use this thing called, they're talking of this corona cutting, where in some centers they have even a glass box where you can intubate the patient when you're fully donned. You can cover up the patient. So we thought this can maybe apply in your setting, where if you are not able to fully have, well, you have, PPE, but you also want to minimize the risk for aerosolizing the environment. You could have something like this, cover the patient, and you just put your hands under, maybe to intubate the patient, but this is only for an unconscious patient. And we thought you can also do resuscitation when the patient is like this, maybe when your hands are under there and you bagging. The reason for putting this slide here is just to give us ideas on how we can reduce aerosol generation. And if you want to read more about this, I saw a certain study that they are doing in Zimbabwe about a corona curtain and using this polythene, how they are, in their limited resource environment, they are trying to use this to intubate patients and so on. So these are our references, and we welcome your questions.
Okay, thank you very much to our presenters, Steve Thuo and William Little. Such a wealth of knowledge and very good resources here. We have a few questions that have come through, and I'm going to read some of them. The first one is, causes include administration of wrong drug or overdose of a drug, esophageal intubation. This was by Sue Anang. I don't know if it was asking a question or giving us a contribution to our topic today. But then there's another question here that says that kindly say something about the prone position in COVID patient. This is by Agnes Zomo. So to our panelists, I think there's also another question that came through concerning the same. Let me just tie them together so that we can answer them at once. There's another one by George Oguma, which relates to the same. Is prone CPR in the era of pandemic a standard procedure? If yes, how is it possible for the patient who is not intubated? So those two questions can be answered together. Steve, you can go ahead, or then William can add on later.
Yeah, I think Sue was trying to maybe say that giving a long drug is part of the causes of cardiac arrest in the operating room. Yes, it's an aesthetic cause. We don't want to give another dose, an overdose, or a wrong drug, because a cardiac arrest can happen. Esophageal intubation, like you mentioned, can cause hypoxia, hypoxemia, and can be a cause of cardiac arrest. So the vigilance is really important, and you would want to avoid all the reasons why our patient would go into cardiac arrest are things that we would want to address. Now, Agnes asked about prone position in a COVID patient. Yeah, I saw a literature where they were talking of a patient in prone position, they go into cardiac arrest. What do you do? I don't have a perfect answer, but I have a few thoughts. One, if you are doing cases for patients in prone positions, I think are very dangerous as we take care of patients. So I think you have to do all you can to make sure that your patient is safe when they're in prone position. But if cardiac arrest occurs, can the surgeon pause or cover the surgical site really quickly, and you put the patient in a supine position and then continue with CPR? If yes, go ahead and do that. Is the surgeon not able to, is it maybe at a critical step during lumbar spine surgery or lumbar fusion or whatever, you could start CPR briefly when the patient is in position. You just need to go at the center of the scapular bone, do brief as you prepare to put the patient supine. Prone position is not effective to generate a patient's cardiac output effectively to perfuse for them. Okay.
Maybe something to add.
Yes, William.
Yeah. So if the patient is in prone position, what you need to do, maybe the positioning of if you have to do the resuscitation, that is CPR, the positioning of your hand when the patient is in prone position, we're talking of you have to place the hand at around T7 to T10 region. And then a point to note also, you have to do the CPR on a hard surface. This will help you to, when you're applying the pressure, so that the hard surface will help you to actually come up with a good diastolic pressures for the patient. Yeah. But this issue of prone position is a new concept, and there's a limited research on it. And I think we, as scholars, we have to do more research on it and do more reading on it for us to come up with a better answer.
Yeah, it's true. Okay, more questions?
And maybe before we get another question, Steve,
yeah,
and to all the participants, one thing that we have to remember after we have dealt with a patient who has had a cardiac arrest, we should be thinking of post care. What is the care that we're going to give this patient post CPR? And if the patient actually needs an ICU setup or a HDU setup, yeah. And then after you've done the CPR, you've been doing the CPR as a team. So what you need to do as a team, you need to do what is called a debriefing. This debriefing will help you to actually improve on your skills. If you encounter the same case in the next scenario, and during debriefing, you have to have a safe environment, and then place no blame on anybody. You know, this is a fact-finding mission, and you want to find out what did you do well. There are questions that are very key when you're doing debriefing. For example, what did we do well, and then what would we have done differently, and then were there any equipment failures? You know, these questions will help you to improve on your skills if you encounter such a scenario if you encounter such a scenario another time. Yeah. Thank you.
Okay, thank you, Steve, for the answer. Let's move on to the next question. Mubarak Mohammed, I think your question has been answered with that in the previous one. I hope you are satisfied. The next one is asking, in a situation in which you don't have adequate monitoring gadget for PIDs, what do you do?
I don't know what the person was asking. Was it adequate monitoring in the operating room, or because it is ideal? The recommended monitoring, standard monitoring, ASA standard monitors are a blood pressure monitoring, pulse oximetry, ECG, and also the temperature. I don't know if you mean you don't have a blood pressure for a child, or you have maybe a pulse oximeter, and maybe you don't have an ECG, or you have a blood pressure, but you don't have ECG and temperature monitoring. It is important that you advocate. I would encourage you to advocate for gadgets for monitoring pediatric patients. I think if you don't have an ECG, you should at least have a blood pressure and a pulse oximeter and a thermometer, because hypothermia, as we have seen, is a cause of cardiac arrest. It's a reversible cause of cardiac arrest. If a blood pressure is going low due to hypovolemia, we want to know what the blood pressure is. So what do you do? If you don't have an ECG, can you do a precordial stethoscope and you keep listening to the heart rate and the beats? Are they regular or irregular? I think that the COVID-19 situation is creating challenges that are making us think things in a different way. And I think this could also be a good opportunity for us to advocate for more equipment or monitoring equipment, I think. Maybe if you work in a setting where you don't have HMEs or the humidified moist exchangers, this could be a good time to advocate for that. But if you don't have any of these things, be creative in maybe using things like a precordial stethoscope. Like you can use an oxygen tubing, a long one. You connect it to a stethoscope and you use it to listen to the heart rate of a baby during surgery the whole time. That could tell you, is the baby becoming tachycardic, bradycardic, are the heart rates irregular, and so is the heart rate irregular, and so on. But it is, I think, very, very important to have at least a blood pressure cuff, a pulse oximeter, and a thermometer for a child. It's things that you need to push for.
I think that is well answered. And just to add, if you remember the standard ASA, that is American Society of Physiology requirement, the basic parameters that you need to conduct any surgery, you need to have the blood pressure, you need to know the SpO2, you need to know the ECG reading. So, and in children, you need to know the temperature. So those are basic requirements that you must strive to have in order to conduct safe anesthesia. Probably one of another question, we just see which one. At such times, is CPR effective when always a time is vital, considering the time taken to dawn? When patient code into Kenneth Rua, William, could you go ahead?
Yeah. Like we had said earlier, this is that we have already done preoperative evaluation of the patient before we go in for surgery, and the surgery was actually needed. And in OR, we are saying these people who are coming from outside, those people that you are asking for help. And we said when you're asking for help from outside the OR, we're expecting that you inform them that you are dealing with a COVID-19 patient, right? But you guys already, the guys that are already in theater, in OR, we are assuming that, or it is expected that you guys have already donned and you have your PPEs on. So it is only for those guys who are coming from outside that they need to stop and don before they come in, right? I don't think I think I've answered you. So this applies to the help that is coming from outside the OR. But you guys in OR, you already have your PPEs on. Yeah. I don't know, Steve, if you have something to add.
Yeah. So I think we are taking every patient as a suspected or confirmed COVID patient. So in the OR you are done, but you should do the same if you are called for an emergency, maybe in your emergency room or in ICU. Make sure you are done before you do that. There was a question about, and it's good to don early. Let's not, and if you suspect that your patient is very unstable and you might end up resuscitating and you are not done, make sure you don early, because you might end up taking time to don. And I tried this in our SIM center, and it took me at least 2 minutes. We don't want to wait for 2 minutes donning to resuscitate a patient. But remember, William mentioned earlier that if you call for help, mention COVID-19 so that those who are coming can be able to don. Now, there was a question about who runs the code. I think when we are doing resuscitation, it's important that we ensure that we have a team leader. If we don't have a team leader, we are likely to not to do an effective job. So we need to have a team leader whose hands are either free or they are taking part in a less intensive activity during resuscitation. So in the operating room, I think we take the surgeon as the leader, but in resuscitation, I think the person who would be, team leadership is about organizing people, do CPR, do chest compressions, give medication, run the defibrillator. It's about organizing people. So in an ideal situation, any person trained in ACLS can run a code, but I think the anesthetists are normally taken as the people who would run who would team lead a resuscitation situation. And we encourage all of us to keep updating on ACLS so that you become confident in running a code in your operating room. But we need to remember, I think we also need to empower the people around us that we are working with so that they can be able to help organize other people if we are engaged in a mentally challenging activity, or you are engaged in a point where you can't be the team leader.
Okay, thank you, Steve. Just before we proceed with this last question, Steve, can you display the last slide so that the participant can see the CPT code so that they can redeem it? All right, as you do that, there is one question from Florida Kawira. She's asking, now that you had a COVID-19 patient in your theater, what happens to the operating room? Do you leave it for some time without using it?
Yeah, so there is a slide I projected, and we say that slow is good, slow is safe,